From the RSNA, this is the Radiology Artificial Intelligence Podcast. My name is Paul Gee, and I'm a radiologist at the University of Maryland and co-host of the podcast.
And my name is Ali Tejani, and I'm a radiology resident at the University of Texas Southwestern Medical Center and co-host of the podcast. Each month, we dive into the hottest topics in radiology AI and talk with leading experts, thought leaders, and movers and shakers in the field.
Welcome back to the Radiology AI Podcast. This is part 2 of our episode on the role of AI for opportunistic imaging. Enjoy.
I'm detecting a very big theme of body composition analysis, and I'll add on to that theme by just explaining a little bit about my research. So my research is effectively take an input CT scan and then predict whether someone's going to develop diabetes or not, or if they already have diabetes on that CT scan. And the reason for this is just, even though we're pretty good at screening for diabetes with an A1C blood test, it still doesn't quite capture the large amount of people who actually do have diabetes but are undiagnosed. It's estimated to be around 20% of the US population that does have diabetes is just walking around undiagnosed. So we're thinking that maybe CT scans are a way that we can, capture those 20% of people who don't have a formal diagnosis, so that we could say, hey, your CT scan shows that you have a very high risk of developing diabetes, follow up with your primary care clinician to get a test. So in terms of what I'm doing in my actual research, effectively what we're doing is that, one, we've already identified some, hand-picked imaging biomarkers, and now we're trying to see, can we use some deep learning derived imaging biomarkers to make our diabetes classification more accurate. And then on top of that, we're trying to see, and this is also a little bit where the challenge comes in, do these imaging biomarkers actually change over time? And does that change over time actually correlate to changes in severity of diabetes? So, let's say fatty infiltration of the pancreas. Does the amount of fat correlate to a higher A1C or an increased risk of major adverse cardiac events, which are associated with having diabetes, et cetera? So sort of these longitudinal analyses on top of just deep learning work is sort of what I've been doing over the past year. I guess sort of additional challenges, especially in the realm of opportunistic screening that, you have to deal with. It's just that whenever you're talking about predicting risk of developing some diseases like diabetes, like pancreatic cancer, et cetera, you do really need to have longitudinal follow-up data on these patients. And that is often very difficult to get because, whenever you're working in radiology, oftentimes you'll have easier access to your radiology packs, images, and radiology reports. But oftentimes it may be very difficult to actually get the corresponding clinical history of these patients, especially clinical history after you have that initial scan. And, at the NIH, we're also faced with the challenge of we have a kind of old PAC system where everything is in plain text. So extracting diagnoses from other clinical notes is also very difficult. Fortunately, we do have access to a University of Wisconsin data set on CT colonography patients with longitudinal follow-up data. But regardless, I think that, a big challenge for anyone doing opportunistic screening is just going to be having longitudinal follow-up data, especially whenever you're dealing with outcomes that will take years to develop beyond that initial scan.
So obviously, creating these opportunistic screening AI tools is a tremendous challenge, right? You have to collect a lot of data, not only retrospectively, but make sure that you have some form of longitudinal follow-up. But one of the things I also think about is the breadth of different topics or diseases that you can really study. We've talked about diabetes diagnosis, pancreatic cancer prognostication or prediction, or bariatric surgery triaging. So my question for you all is, where should our listeners or other researchers focus their efforts when developing AI solutions for opportunistic imaging? It'd be nice if we could tackle everything, but there's 24 hours in a day. We've only got so many years in our careers. So what do you think is the best way to focus? And number one, and number two, how do we deal with all of these different solutions coming out? Because as we talked about a little bit, imagine that our job as radiologists, we've got a bunch of opportunistic screening results coming into our reports. I think that's very exciting, but I can also see a future where we're just inundated with dozens, if not hundreds, of possible findings. So I'm curious what you all think about that.
If I understand correctly, I think part of our role as radiologists when we're doing this sort of research is not to stay siloed in radiology. we can't really push this research forward and really have clinical impact without bringing in all of our all of the other specialties that are involved in these results. And I think that's really been the biggest challenge, is that we need to, if we, for example, Michael is working on pancreatic cancer detection, so he needs to work with oncologists and surgeons and that entire group in order to bring them along with him and make sure that this has the right clinical impact. So I think it's not necessarily about having a whole slew of opportunistic screening results, but it's making sure that each of them really has the evidence behind it, and we're bringing the rest of medicine along with us as well.
I would add that this is not just going to be an issue for radiology. This is going to be an issue for the whole healthcare system. For example, we published a paper last year in Nature Communications showing that you can use ICD code trajectories, just the time series of ICD codes, to predict the future development of pancreatic cancer. And the group that we collaborated with out of Denmark has shown this for other disease entities too. That doesn't require any radiologists involved, but the healthcare systems are going to have an infrastructure in place to respond to these risk flags, make sure they're handled in a patient-centric and appropriate way, and that they come to some appropriate resolution. Right now, at least I'm not aware of systems that actually have a robust plan in place for how to do that. That's going to be a really important conversation with hospital leadership, with the societies as they're developing guidelines around these new AI-based screening tools. I think it's going to change the way that some of the people in medicine practice over the next few years, but we don't have the infrastructure built out yet to do it well.
I'll also add for like the AI researchers in the audience, one thing that has always been a challenge whenever it comes to opportunistic screening is that, if you want to actually look at like one particular organ in the past, like you needed to develop your own segmentation algorithm and then validate that segmentation algorithm before like applying it to a larger cohort. Tools like Total Segmentator will make things easier, but Total Segmentator only works on CT. There really is a need to like actually capture as many imaging modalities as we can. So developing like similar tools for MR images, X-rays, et cetera, will help us really capture a wide breadth of patient populations, not just those that get a CT or perhaps a chest X-ray, because a lot of AI efforts are focused on chest X-rays. So I think that, for AI researchers, if you want to look at MR images, that would be greatly appreciated.
All this talk about the use cases and, the potential out there and what we're working on. I don't know, Paul, it's got me excited about how we're translating these to practice. I would love to see each of these, right, as I return to the workstation after this talk, if I'm on call, for example, or a busy daytime shift too. But oftentimes it's not as simple as just taking an algorithm, right, that we've developed and just deploying it in production. What are some of the barriers limiting translation of these solutions or others that you may know of in this space of AI for opportunistic imaging? What's stopping us from using them on a day-to-day basis?
So I think that there are two different pieces to this. There's the approval of a device, and this gets into the FDA, which has relatively low bars for approving radiologic devices and algorithms and such. So I think that's not the main barrier, because there are hundreds of FDA-approved algorithms out there now. I think the big issue is use cases and clinically actionable data. That's where I think we need to be focusing our efforts right now in radiology, identifying a few killer applications, if you will, where people are actually going to want to take these opportunistic results and do something with them. I think that the work that Perry Picard and Ron Summers have been doing is really at the tip of that spear in terms of bringing things like automated calcium scoring for fracture prediction to the forefront of actual practice possibilities. But I think that's where we need to have an application that is going to drive patient care, that's actually going to change the way that we're taking care of people, that might supplant something like DEXA as a routine osteoporosis screening tool in clinical practice. That's what I think is going to break down the barriers to implementation. From there, though, we run the risk of ending up in like the Great Pacific Trash Pool, where we have thousands or tens of thousands of FDA approved algorithms that are all trying to kind of scurry into this space. And we're going to have to be responsible gatekeepers to make sure that clinically meaningful things are the only things that get through and start to occupy our attention.
One other barrier that I often think about, just in general with AI, but certainly for something like opportunistic screening, is trustworthiness. We think about things like interpretability or explainability. How can we trust that these things are working well? I'm curious what you all think about just from a research methodology standpoint. I feel like a lot of these papers, you train on a certain number of images, you then test them on a smaller subset that have been manually segmented, and then you kind of go to town on fold increase in images thereafter. But how do we do this in the real world? How do we ensure that these things, one, are doing the segmentations or calculations correctly? And two, how do we interpret some of these maybe more, let's say, beyond human vision kind of findings and make sure that they're actually learning what we want it to learn, which is a disease of interest, as opposed to doing something like shortcut learning?
I think I'd like to start with this question because it goes back to my initial work that I got to do with Michael. So we were starting with an algorithm for this body composition segmentation. We had an internal data set that it was trained with. There was external validation that was done. And I came in and we were trying to apply this at large scale. So we first had to kind of increase the automation, but then we needed to also do some QA on the inference. And so we were able to initially run this on over 28,000 scans that were all of the abdominal CT scans that had been performed at Mass General Brigham in 2012. And what we did was we tried to do some monitoring. So we didn't check every single case, but I manually looked at 2% of those cases and saw, what sort of problems were we having with segmentation. Now, this was something that I could visually check. It was an interpretable solution that we were using. So I was looking at segmentation. So this was not something where it was not a vision problem that I couldn't check myself. But that did give us some understanding of what the approximate failure rate was of the algorithm and places that we were running into issues. And then we also did run a reader study as well, where we did some head-to-head comparisons with human readers with cases that were outside of our initial validation sets that we use, both internal and external. So I think that gave us a lot more confidence, and continuing to monitor these algorithms and how they work, I think, is really important. You don't want to just let them go and see what happens, but you do want to kind of keep checking in and making sure that you don't have model drift or some unexpected considerations as you move to different, slightly different types of data from different institutions and technologies.
The interpretable AI question is very relevant here, in that with body composition, this is a very interpretable task because you're trying to produce a map of the muscle, and you can look at it and say, does that look like it's the muscle or not the muscle? And that made this a relatively straightforward thing for us to validate. I think it's much harder when we're talking about, for example, risk from pancreas radiomics. We don't know what pancreas radiomics really mean yet. There's some work going on to try to understand the biological pathophysiology that underlies changes in the pancreas that might drive that. But for now, it's kind of a magic box where you put in some CT images and a risk score comes out. It is correlated with what happens down the line, so that's exciting, but it makes it very hard to know that you don't have some other confounder that's important. And as an example, I recently reviewed a paper that was overall very well done, but there was a little problem where the cases were all done using an oral water protocol, and some of the controls were not done with that. And these algorithms are very sneaky. If there's some signal like that in there, they will definitely find it. And if that's the driver of your risk score, it's hard to know that unless you've done really great work in interpretability. That's the kind of thing where you just need to validate in a data set that is not yours, that you don't have control of. You don't have control of the algorithm running. Someone else does it and sees if your algorithm actually still does what you think it's going to do in a completely different data set. That's the gold standard. That's what we're tiptoeing into in a lot of these algorithms right now. And I think the next couple of years are going to be filled with papers where people have said, okay, I've built up this algorithm, I've done all the internal validation, and now I handed it off to someone else, and either yes, it works, or no, it went down in flames.
Yeah, I'm hearing a lot of great points about perspective validation of these algorithms, and I completely agree. As we consider taking some of these algorithms sort of out of the research realm and into the realm of things that radiologists will use in a widespread manner, one of the things that we have to reckon with is FDA approval. So for usual products in like the radiology AI space, they'll go through like the 510K process. In that case, they'll find some predicate device that does something similar. And then the FDA, if they find that there's substantial equivalence, will move on and say, yes, this device is cleared. But whenever we're talking about opportunistic screening, sometimes we're dealing with sort of devices, I should say, we're dealing with tools that will diagnose things that often may not have a predicate device. So the question really is, how should the FDA deal with these opportunistic screening devices that are going to eventually come to their consideration in the next few years? Should they go through this 510K process and hopefully there's some predicate device out there? Or should there perhaps be like a new process or something else regarding how these devices are actually regulated?
So I think this is a really interesting issue, and there's a lot of gray uncertainty in this domain right now. I'm not an expert in the FDA approval process, so I'm not going to try to represent that. But what I will say is, for opportunistic screening, we're often talking about developing estimates of risk of some future event. That puts it into a strange place relative to the FDA, and that we're often not talking about a device in the sense of like a scanner or a piece of hardware. We're talking about a set of methods. The Gale risk model for breast cancer is obviously not FDA approved, right? It's a mathematical model. Drawing the line between that and, say, a neural network that is estimating a risk model, it's a very difficult thing to say where you go from the device to the kind of mathematical method. I don't know where that particular piece of it is going to land, but what I think the current situation as it stands, where many of these algorithms are going to go through the predicate device pathway and are going to have a relatively easy approval process. We've certainly seen a large number of algorithms that have gotten FDA approval. That's going to be the easy part. The hard part, again, is going to be actually showing that it does something that we care about, and having institutional and kind of medical society standards in place for how we guide the use of these. In much the same way that the NCCN guidelines help to manage cancer care, we're going to need to have guidelines for how to manage these. What will ultimately surely be tens of thousands of approved devices that are available for our consideration.
All right, so we're heading into the last few minutes of our time together. Before we go, I want to give you all an opportunity. If you have any last parting thoughts on the topic of opportunistic screening or AI in general for our listeners to end the podcast with.
I think that this is a very exciting time in AI and in radiology. The changes are coming very quickly, but I think that we're seeing now is a lot of really positive, exciting work that could add to the value that we bring to the healthcare system. If I can bring up one paper that I really enjoyed last year, there was the Pandas paper that came out of China looking at using non-contrast abdominal CTs to detect pancreatic cancer. If you're going to come up with a terrible task, like this is basically the worst task you could possibly imagine for AI, and the area under the curve for detection was 0.996. That's ludicrous. I've never seen 0.996 for any task at all for anything. And that they were coming up with detecting one of the hardest cancers with one of the lowest contrast studies you could think of for the pancreas is pretty extraordinary. Now, there's some limitations. I don't think it's actually going to do that in the real world, but it speaks to how rapidly transformational this is going to be in our field, and how important it is that we as radiologists remain engaged with this and remain the stewards of responsible use of AI in healthcare imaging.
I wholeheartedly agree with everything you all have said. And as someone who is hopefully going to be entering radiology residency in the next couple of years and starting a career as a future radiologist, I really hope to see a little page appended to the end of the DICOM that says like, oh, this is the percent risk of pancreatic cancer. This is what the body composition of your patient actually looks like. So I'm really excited for what this field has to offer and how it can really change how radiologists practice in the United States and beyond.
I want to thank everyone for this opportunity to talk about opportunistic imaging and screening. I think this is such a exciting and interesting area of research that really is going to affect all of us. So looking forward to what the future brings and continuing the conversation. I know we've been on the body composition and pancreas train, so I just want to highlight one of the other applications that I think is as exciting, if not even more so, and that is coronary calcium scores. I've been reading a lot about this recently, but coronary calcium scores are a widely accepted imaging biomarker that is actually the strongest predictor of cardiovascular risk in asymptomatic individuals. So really, highly used. Lots of our colleagues in cardiology and in medicine are thinking a lot about coronary calcium. And there are AI models now that are automating that process, because at a lot of places that's manually done with 3D labs and things like that and costs additional to patients. But if we can calculate these on non-gated CTs, and instead of having qualitative information being read from chest CTs about how much coronary calcium a patient has, saying it's mild, moderate, severe, things like that, if we can have real scores that can be actionable for patients from routine imaging, I think that is really an exciting place to go. And I think we should be doing that. We should be augmenting cardiovascular risk assessment with tools that are already validated.
All right. Well, this has got me really excited and optimistic for the future. Thank you all for joining us here on the Radiology AI podcast. Kirti, Abhi, and Michael, it's been an absolute pleasure, and really appreciate your time.
Thank you.
Thank you.
We hope that you've enjoyed this episode of the Radiology Artificial Intelligence podcast. Shout out to Uriah Shemchisen for our podcast music and to the RSNA podcast staff.
Email us at podcast@rsna.org anytime with questions, feedback, or suggestions.